Thank you so much for inviting me today. I'm so excited to be here, and actually, it happened to be today is my birthday, so I'm so happy. Oh, thank you. So, could you put up the slide, please? This is, sorry. Oh, here we go. Okay, great. Yes, so I think, I would like to, compared to the other presenters, I would like to share my lab experience in the Houston Methodist and in DHI. So this way. So conflict of interest, I received like NIH grant and then also Houston Methodist research grants and no disclosure related to this presentation. So I think Dr. Mironakis has already touched in his presentation. Drug resistance bacteria is a big issue in United States as well as the world. So one of the estimates showed that 1.2 million people died 2019 due to the antibiotics resistance infections. And then estimated deaths will increase 2050. So I think the challenges in the healthcare is how we optimize those antibiotic therapy when you seeing those people who have the drug resistance bacteria or risk of the drug resistance bacteria. And then also, I think this is a unique in infectious disease. We wanted to preserve the newer antibiotics or important antibiotics to prevent those people or bacteria developing a resistance. So, and then also the other interesting, important things in infectious disease is those antimicrobials are prescribed across all specialties. So I think having a good predictive model and reducing like those optimizing antibiotic therapy and then reducing unnecessary antibiotics will impact in a big community as well. So my lab's goal are we wanted to try to create a comprehensive infectious disease AI model. So that way we can support bedside physicians and when we deciding antibiotic therapy, even like without involving the infectious disease physician, try to provide the tools to predict the antibiotics. So when we're looking at those infectious disease AI models, and especially the stewardship field, I feel like there are three big buckets. This is also unique in infectious disease, we look at the pathogens, like we wanted to see what type of the infections the patient could have, and then also if that bacteria could develop the resistance or not. The second thing is the patient outcome. So we would like to know like what's the risk of the mortality or the other like worsening infection. And then in the end, when we start prescribing antibiotics, we also would like to know what is the optimal dosage of the antibiotics. So today, since we have a limited time, I wanted to touch on the first two, like pathogen specific and then patient outcome, the research we have been doing. The other things, like as other presenters already touched on, I think, as you know, like as soon as the patient hit to our healthcare, we start generating information in the EHR. So as you can see here, like the patient journey, like once they come to the clinic, they will get the vital signs and then some information, and they could come to another admission, or they could have a claim data, or they could go to the nursing home. So the traditional medical research are, those journeys are aggregated into a cross-sectional data. So, and then if we, put it into a cross-sectional data, and the concern is, we could, like those informations, could have like limited input, as well as you will lose the temporary event. So our labs are interest were how we develop like deep learning model to kind of take the sequence event, and then let's try to apply this in the infectious disease field. So for example, like when the patient admitted to the hospital, as you know, like they have daily events, and then all infectious disease specialists are looking at those daily events, and then try to predict whether or not they need different antibiotics or they don't need antibiotic therapy or not. So the first project we did, this is in my previous institution, was try to find like the good target, which is going to be a MRSA, which is one of the common bacteria we find in the hospital, and then try using a deep learning technique and then time sequence model, and then try to predict positivity of the MRSA. So, and I think a lot of like previous studies are focusing on at the time of the cultures or at the time of the index time. That's the blue arrow. But what we wanted to do was we also wanted to predict over, like give some window period, not only like just a day, 7 days or 14 days, because I think it's really depending on where you work or work specialties, or you are seeing a patient in a clinic or outpatient, you could have a different things. And then also, if you're getting admitted to the hospital, then you may have additional tests done on the next day or so. So we wanted to cover broadly, so that way this will be helpful for the physician to decide whether or not you need a specific antibodies to treat this bacteria. The other important good things for the sequential models we are trying to develop, or we developed, is, as you know, the patient comes to the hospital multiple times over time. So they could have first admission, but they could come back with different infections the second time. So we wanted to integrate multiple events over time. So that way we would like to see how the model learns, and then also can be more personalized depending on patients. So this is still in my previous institutions. We collected the data from the Memorial Hermann Hospital. We identified 8,000 patients. And then also we used the external validation from the MIMIC4, which is a de-identified data set. And then we had 156,000 patients. And then we tried to see how our model did. So this is a highlight of our results. But basically, our deep learning model actually did better compared to other traditional machine learning model, and using those sequential data. We also compared the physician's prescriptions, such as and then we identified net benefit of this model. We can potentially reduce the amount of the antibiotic therapy. And then also we can optimize antibiotic therapy who has a severe infection, such as MRSA bacteremia. And then we also show the risk stratification that, as you can see on the top, on the incidental curves. And we are successfully able to show the difference between the group. Then the other things we did was we wanted to see if the patient has a recurrent event over time, coming back to the hospital, how our model did compared to the other model. And then x-axis of this graph, and that is the number of the events for each patient. So as you can see, as number of events go up, and actually those sequential model or deep learning model did better. So we this is a proof of concept. If we use large data sets with the deep learning, with the EHR, potentially we can help improve the model outcome. So I decided to join Houston Methodist 2023. And then there are a couple reasons I decided to move here. One is my expertise in transplant infectious disease. I treat those high-risk patients. Obviously, as you know, we do those kind of clinical studies or data science research, and then I would like to be in an environment where I can do the research. And then, as I said, the Houston Methodist is one of the largest solid organ transplant center in nation. And then also during the COVID-19, I noticed Houston Methodist produced a lot of good papers from the informatics, and then I was impressed. Even despite such a pandemic, they were able to produce those. And then also our division chief, Dr. Arias and Dr. Miller, they have strong experts in translational research in drug resistance bacteria. And then I think as we discussed from the other presenters, I think multimodal approach will be helpful. So I think having those basic research environment is also, or translational research environment is helpful for me. So after I joined Houston Methodist, obviously my interest is leveraging this big data from Houston Methodist, as well as the de-identified database. So luckily, Dr. Jones, Steve Jones, was able to provide me the large data set from the Houston Methodist. And now I have an infectious disease database which contains more than 1 million patients record, and then that is regularly updated. And then I can construct either sequential or cross-sectional database depending on my need and with my research lab. And then I do not touch on today, but we also have access to our EPIC Cosmos data sets, which include millions of patients. And some of the infectious diseases, as you know, may not have a good incidence. In that situations, we can leverage those large data sets, or we can train on those models in a large data sets if we don't get a good results. So I think that many questions are not addressed yet. We are making those drug resistance bacteria, the models for each individual bacteria as well as the resistance. But at the same time, I saw like many questions are not addressed well. The one thing is, as physicians, as you know, the microbiology cultures are not always positive. So infection could happen like without positive cultures. And also, some of my patients, the immunocompromised patient could be on some antibiotics already. And then in that situation, the sensitivity of the microbiology goes down. And then also, we often start empirical therapy at the front. But do we need 2 or 3 antibiotics? Or the fevers or leukocytosis, which is one of the markers for the physicians to consider the infection, but it can be, from the non-infectious. So how we can differentiate, those. And then also the antibiotic therapy, we sometimes use one antibiotics, or sometimes we use combination therapy or adjunctive therapy as well. So such as like a steroid or anti-inflammatory. So how we could potentially answer this question. So when DHI is announced, I was so happy because this is my area of the field and an interest. So I quickly contacted Dr. Sabrawal, the ASH, and then so we wanted to see those 3 or 4 different scenario, such as like when you're seeing a patient up front, when we wanted to start antibiotic therapy, whether or not this antibiotic therapy will be helpful or not. And then the second scenario in the middle is, for example, if we combine antibiotics or change the antibiotics, does it help actual patient outcome or not? And then the third thing is whether or not we can safely stop the antibiotic therapy. So we bring this idea, and we decided, why don't we try to use this sequential model and then use the counterfactorial network, which is a sequence-to-sequence deep learning architecture. So that way we can estimate the treatment effect by simulating the outcome and the alternative therapy, such as stopping or combining, and then do that. So we are able to start this project and then write clinical questions, and then as well as the outcome. And then also, they bringing like Rice modeling expert, identifying the right model for the architecture. I hope I can share the results soon. So far, we started this project a few months ago. And then what we decided is, one thing is in our future goal is bring this model to the bedside. So we wanted to identify the interpretable and intuitive outcome measures to bring the information to the physician. And then as you can see in the middle, we are complete the data preparation, which is it takes the bulk of the time. And then finally, I was able to collect the data, more than 100 different continuous measurement, as well as large categorical values, which is including medications. And then we started model training. So hopefully, the next few months, and then we can bring these results back, to the community or to the conference, and to the conference, yes. And then, so I think conclusions and then a summary, I think leveraging a big data can make a patient care more personalized. And then I think throughout these DHI collaborations and then strengthens the project. And then I'm looking forward to these collaborations, and then also excited to hear the other presenters' presentation, because they can elaborate the collaborations, and then I can bring in additional data into here. And then also some of the model is already showing the good results. So I think in our lab, we would like to have the clear pathway to bring the innovation to the model to the bedside. So that way we can do our prospective validations and then implementations in the near future. So this is my acknowledgement. Obviously my division's chief, Dr. Arias, and then also the Department of Medicine, Dr. Milonakis. And then also I have a long collaborator from the UT as well, across the TMC. And then also my lab member, and then the transplant team, and also the DHI. So thank you so much for your attention.